flow. This is a normal Doppler of the descending aorta. Since morning we have shown you descending aorta Doppler. This is the lower limb Doppler in the descending aorta, and you see the systolic flow. Now let us see what happens in the coarctation. Dampening of flow. You see the systolic phase is continuous with the diastole. You can compare the Dopplers? Yes. This is dampened flow because the obstruction is upstairs, so you are having a damp flow in the descending aorta. Suprasternal view, normal flow, normal arch, normal flow. Since morning we have seen a lot of times, this is the normal flow. Now what will happen in coarctation of aorta? The turbulence happens. See this arch, and this is the turbulence here. Can you appreciate this? Yes. This is the turbulence, the increased velocity because of coarctation. Now here in 2D also you can see a shelf. If you can start appreciating, but I would prefer a color flow in the arch to see the turbulent flow. So if we start with the imaging here, so descending aortic flow, normal flow is like this, whereas coarctation flow is like this. It will not touch the baseline in the descending aorta, damped flow, which we are trying to show. The color also, this phenomena you can appreciate in color. When you see a long color, it's not staying. Subcostal view, descending aorta in subcostal view. And this is the normal flow of the arch, pulsatile flow, when you see the suprasternal view. So here, let us see what happens in Doppler in the coarctation. So this is again a color flow. See this? Okay. This is the normal arch, and then you have a turbulent flow. This is the site of coarctation. So I will tell you now. I am coming to that point. So shelves means So here normally you have a small shelf with presence of PDA. So PDA is here, so shelf will be here, that is anterior shelf. But if you have a coarctation, the shelf will be posterior here. So shelf is here, posterior shelf. So in the arch, so if you make a arch view like this, arch view, you have a coarctation here. Normally you have PDA here. So here you can have a shelf, normal shelf, which is PDA shelf, anterior shelf. But if you have shelf posteriorly, that is site of coarct. So
it can be from both sides like this?
Unlikely, because this shelf will come from posterior end only. It doesn't come from anterior end. Lot of angios has been done and biopsy studies have proven the shelf will be mostly posterior. Isthmus means?
Beyond the,
no.
beyond the left subclavian.
Yes. So subclavian is some left subclavian is here, suppose. So this is the site, this is the isthmus. So isthmus is whole now, because you can see from subclavian. So this site is whole is isthmus. Yes. So again, this Doppler you have to understand very well. Descending aorta Doppler will help you a lot. Actually, if you start doing the Dopplers in the descending aorta, see this Doppler. This is very reliable.
The spectral through the coarctation.
Through the coarctation,
Mild, moderate, severe, variant.
I will come to that point. I will come to that point when you decide the severity. Now, this is another case. So what will happens in the coarctation is, when you have lower limb BP down, what would happen to upper limb? So left subclavian comes here, left carotid comes here, and then you have right subclavian, right carotid, like, okay. So the parts who are below this coarctation site would have lower pressures, they would have upper pressures. But there are variation in the arch vessels. Suppose this is left subclavian comes here, what would happen? The pressure, of course, radiofemoral, but this left upper limb will also be low pulse. So lower limb and left upper will be involved. Left subclavian involved means This one. This is uncommon scenarios, but this happens. Now, but still, right upper limb is getting hypertensive. Carotid is still getting hypertensive. Brain is getting hypertensive. Now, one more anomaly is aberrant right subclavian. Suppose this subclavian artery comes, aberrant means comes below coact, like this. Then right also gone, left also gone, and lower limb also gone. Only carotids are remaining. So carotids will be bounding, all other pulses are gone. They are uncommon scenarios. In my life, I have seen only 2 cases where this scenario has happened, where you have everything from coact side. One of the cases I will show.
Are they survive beyond infancy?
Of course. Why? Because this is not severe. If they are severe, it will not survive. So depending on severity, survival will happen. So this child came to us with sudden shock, and I will show the angio. This patient's angio we did, just to document that what is the coarctation site. So see this. So this is the site of coarctation. Left subclavian coming from coact site, right subclavian is aberrant coming below the coact site. So everything is below the coact site. So there is no pulses anywhere except the carotids. So this patient came with no pulses, no perfusion, because we checked the carotids and we thought this might be coarctation. So in a coarctation patient, in a shock patient, always check the carotid also. In a child, in a newborn, in the adults also. When you are not getting pulses anywhere, look for carotid also. Understood? This patient underwent balloon dilatation and stable after that. So this is another malformation which can happen and defy the clinical logic of difference in upper and lower limb. Okay, this is adolescent with hypertension. So child was asymptomatic, came with the hypertension to us. Okay. This patient underwent was planned for a stenting. See, I am trying to show the angio. See this coact site, and there is a PDA. This is the aortogram. You can see the catheter. This is the ascending aorta, coact, and the PDA. And we did the covered stenting here, which will cover the PDA, and the arch was open. So this can happen in the older children. Stenting is happened in the older children, not in the younger children. So how do you decide when you see a child of LVH? First thing I want to rule out is LVOT obstruction. So I am trying to see aortic stenosis. So this patient, the LVOT is clean. There is no LVOT obstruction at the aortic valve level. And this patient, if you see, you have a bicuspid aortic valve and doming aortic valve, aortic stenosis. So LVH patient, you have aortic stenosis here. Now, one more patient with LV dysfunction. Okay. क्या हो गया है? I'm not seeing the no. Okay, but you know this is LVOT, aortic valve, and you can see a membrane here, subaortic membrane. So when you see LV dysfunction, LVH, rule out aortic valve disease along with coarctation, or because this can present like this. Now, suprasternal view. So again, suprasternal view, turbulent flow, and I want to see the Doppler now. What happens in Doppler in the suprasternal view? This is a Doppler. You can see the velocity reaching 3, and here the most important concept is diastolic flow. So if you see a flow, this flow, suprasternal Doppler here, what I am seeing is normal flow like this. See the normal flow? The diastole should not involve. But here, if you involve the diastole, then like this, you have involvement of the diastole. So trace is like this, it's not reaching to the baseline. So that is significant coact. Whenever you see a gradient in the arch along with diastolic tailing, that is significant coact. The absolute value is 20, but suppose you have 30 gradient to call it coact, but there is no diastolic tailing, this is most likely non-significant coact. The diastolic phenomena is very important to call it coact, because there are few concepts of pseudocoact. So if you have 30 gradient, 35 gradient, but there is no diastolic flow, tailing, then this is not a significant coact. This may be a pseudocoact. In an older child, I would do a CT scan. In a younger child, I will follow this patient if there is no diastolic flow. In adults, I am worried because there are limitations to the imaging. So I would like to see the CT scan to confirm the coact in such scenarios where I am getting gradient. But if you have a diastolic tailing, then this is a coact for sure. And if this color flow is turbulent, then we know this is coact. But this color flow can be pseudocoact also if you don't have a diastolic phenomena. You understood this point? It's a very important point to call it a significant coact. Now assess the rest of the arch.
Appearance is important, the spectral appearance, sawtooth appearance.
So the sawtooth appearance is this only. That's what we are trying to show. The diastolic phenomena. So some people call it a sawtooth. Yeah, diastolic phenomena is a sawtooth appearance. Some people call it a sawtooth also. Then rest of the arch has to be assessed. Rest of the arch means you want to see the ascending aorta, transverse arch till descending aorta. So you have to assess the arch. So see this arch. The arch, other arch parts is normal. So what I am trying to say, ascending aorta, transverse arch, distal transverse arch, other parts are normal. That means this is just a coarctation. Discrete coact can be managed with simple therapy. Now what are the guidelines for coarctation management? We have guidelines. I will not go to these guidelines, but it's available everywhere. You go to this article of IAP guidelines 2019, and there are every disease has been covered in that guideline for management of the disease. So NS Pediatric Cardiology APC 2019 guidelines. But for a coarctation, if you have LV dysfunction CHF, you talk about immediate intervention. Normal function, no CHF, and mild appetite hypertension, you are waiting till 3 to 6 months. So hypertension is the indication for intervention. If nothing, no hypertension CHF, normal LV function, 1 year you can wait in the coarctation. Mode of intervention, neonates go for surgery. Critical ill who are not for surgery go for a balloon dilatation. Infants or adult children will go for a balloon dilatation. Older children can go for a stent, more than 25 kg. That's all is for the coact. If you want me to go for the PDA, I can go. Otherwise, we can see the patient, sir. What do you say, sir? Okay, sir.
If there is any value like 20, more than 20 is mild, 22,
No.
40 moderate, more than 60.
No, it's not like this. So if you have end organ damage, then this is significant. So it's not mild, moderate, severe. If you have LVH, you have organ damage, you have LV dysfunction, shock, this is severe coact. Otherwise, there is no hypertension, no LVH, no CHF, this is mild coact. That's how you manage it.
I've got a few questions. Suppose I've got a coact and my LV function is poor, then how will I assess that patient?
So when you have LV dysfunction and there is a coact, you are talking about significant coact only. This means end organ damage has happened, you have to go for an intervention. Answer is simple.
So we don't rely on pressure.
Precious, no, you are not talking about this.
Coact with PDA.
So coact with PDA in the older life, in the older age group or in the newborn age group, there are two groups. Coact with a large PDA in the younger age group, newborn age group, difficult to appreciate what is happening. What we do, we wait for the PD to get smaller, because when the PD is smaller, the Doppler will give you a signal, good signals. So, but if the PD is large, then you can't assess the coarctation site by Dopplers. Then how do you go about it? By the other markers. LV, no, not by the CT. CT will give the same answers. CT will give the same answer. Whatever is in the echo, CT will be showing the same thing. So if you have a PDA with coact, depends. First question is large or small PDA. If it's a small PDA, the coact gain is reliable. Small PDA will not lead to so much of this dichotomy. But it's a large PDA, then I am concerned. What I would wait is PDA has to become smaller in the younger age group, newborns. So you wait for the PDA to get smaller, follow them till the PDA gets smaller to assess the arch. In the older age group, like this child, these patients with large PDA, severe coact, suppose coact is there, I want to assess what is the severity of coact. What I would do, I would go with the LVH and hypertension. If hypertension is there, LVH is there, I am intervening, otherwise I am following this patient. You understand? In those cases, you go for the end organ things, hypertension and LVH. If LV dysfunction is there, answer is clear. If LVH is there, this is significant coact, you are managing this. If hypertension is there, this is significant coact, irrespective of PD, you are managing this patient.
that, like suppose we have PDA with a coax, we close the PDA?
No, it's a risky thing.
Is it risky?
Risky thing. If you are going for a PDA, you do the quad also simultaneously. Why do you want to do?
I asked this question to a couple of people. They said, let's close the PDA and wait. How does the coax behave? Because both of them are interventionable.
Actually, PDA with coax in the older age group, PDA will never close.
Yes.
So if you close the PDA, only then when you are saying no, coax is not there. Your judgment is coax is not there. I think it's only a PDA. I am getting an artifact of the coax. I am not sure. I am doing the PDA and let's see then the angiography. That's a separate issue. But if you say PDA and coax, then I am handling both cases together.
And his point is very valid. If you have a left ventricular hypertrophy with PDA, obviously the coax is similar. Because otherwise PDA will not produce hypertrophy. PDA will produce dilatation,
थोड़ा सा नीचे
but
करेंगे.
not hypertrophy. That's how we differentiate when we have these joint lesions coming together.
ये ले आओ. Screen ले आओ ये वाला.
So change करेंगे. Hello, screen change कर दें. Good morning.
जैसे इन लोगों को चाय पिलाई है आपने?
हाँ, कॉफी पिलाई.
कॉफी पिए, हाँ.
लेकिन वो क्या वो उसके साथ भगवान के साथ बैठे रहते हैं.
ठीक है.
हमेशा पाठ
बोर हो
पढ़ते
रहे हैं.
रहते नहीं, पाठ पढ़ते रहते हैं. वो पूजा पाठ पे लगे रहते हैं सब लोग.
ठीक है. That is also good.
हाँ,
That is also good. Someone is doing at least.
हाँ. लेकिन कौन सा पूजा पाठ है वो प्रॉब्लम है.
So this is what situs, what structures again. So this structure, IVC. Why this is IVC? Why?
Respiratory collapse.
Yes, collapse. This one, aorta. Why aorta?
अब तो समझ से खाली है बोलो.
Okay. So situs inversus. Why? Slit like is because it's more variability. Patient may be hypovolemic. So I will go Doppler then. Left structure Doppler. Let's see the Doppler.
And you have to be very careful now.
Doppler.
No. Look.
Left side.
This is squat.
अभी तो बताया मैंने थोड़ी देर पहले. Damn, this is damn flow. I am on the left side. I have seen the pulsatile aorta. I am sure this is aorta. And this is damn flow. What is this? Coax, yes. So you understood now. Simple solution, descending order Doppler, and you diagnose the coax. Now let's see the IVC Doppler. See this? This is the venous flow. So again, IVC, and now I will show descending aorta color, which I was demonstrating just color. See this. Red तो रहेगा ही. Non-pulsatile, staying in diastole. So you have this eyes have to train that this is not a systolic flow. This is staying in the diastole. Continuous flow. You understood? Yes. Now Doppler again. Yes? Confirmed? Yes. Good.
So you made the diagnosis already.
So now, okay, one more thing is here. Someone asked me in the morning. This is also coronary sinus. Yes. See this. So there are two possibilities of dilated coronary sinus. Yes, I have a chocolate still remaining chocolate. Dilated coronary sinus DD. That is not an answer. 2. LSVC is one thing. And unroof होगा तो dilated coronary sinus नहीं होगा. Second, 2. That's all is 1 DD, no? 1. 1 DD is LSVC. Second possibility. In fact, there are 3, but I am asking for only 2. DD. One is LSVC draining into coronary sinus. Bilateral SVC, PLSVC, whatever you want to call it. All is same thing. Second, so what else can drain into coronary sinus? That will give answer. And chocolate is ready. Unroofing is forget about the coronary sinus. Azagus vein, no. Coronary sinus, no. Azagus vein is too far from the coronary sinus. Fistula, no. Coronary sinus fistula. AP window, no. Yes. But ये ले. Since morning I am waiting. Since morning I am waiting. Pulmonary veins, coronary sinus TAPVC. Chocolate pass कर देना उसको. Pulmonary veins draining into coronary sinus TAPVC. हाँ तभी. हाँ okay. So great. But I am happy someone could get the chocolate today. At least one. I have more. Let's see.
We should ask a simple question.
So I am trying to.
Whether this patient has got coarctation of aorta or not.
ड्रेस चेंज नहीं किया है, कैसे करेंगे सर?
हो जाएगा, इधर कर लो,
थोड़ा लेफ्ट टर्न,
करवट ले लो,
थोड़ा ड्रेस चेंज करो.
करके वो डाल.
हाँ ड्रेस चेंज करो. So I will go to the fourth chamber now. So what are the associated anomalies with coarct? Coarct we have seen. Yes, and sorry, PDA, yes, and more common. More common.
One more, something aortic.
One is bicuspid aortic valve. Second, common anomalies with coarctation of aorta. Yes, Schoen's complex. One more chocolate has to go. दे दो उसको, वहाँ पास करो. So Schoen's complex we have to see. That's why I'm looking at the mitral valve. I'm trying to see whether we have mitral valve normal or not. Membrane, subaortic membrane, supraortic membrane. So mitral valve is okay. I am seeing the LVOT now. Everyone is going with me now. This is the LVOT. I am seeing the aortic valve. I feel this is not normal, the aortic valve. Let us see in the other views. Yes, 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 yes. Mostly we have bicuspid aortic valve. So let me try to profile. Not accustomed with adults, so.
It's difficult to profile this bicuspid aortic valve because flow velocity is higher in this patient. It's about 1.9, 1.8
Okay.
meters per second
Okay.
was there.
Zooming, yes, but still I am not able to see. I will see some other views. Let me see. Okay, I will come back to this. Let me do this first. Yeah, so you can see LVH now. Yes. And no AS, no AR. That is sure. We are still not sure about cusp, but AS, AR is not there. RVOT, this is the RVOT, and I will do the Doppler here. So RVOT is clean, no PS. And let me see the two pap muscles. Yeah, so this is one posterior and this is anterior. So I am ruling out Schoen's complex. Yeah, so that's why Schoen's complex is that only, no? So I am trying to see two pap muscles. Yes, they are there. Aortic valve, I am not sure till now. Okay, let's go the arch straight. See the function is good. LVH is there. So she must be having significant hypertension. Must be having. उधर देख लीजिए.
In fact, she came with the hypertension.
Okay, okay. So this is the suprasternal view. We all are seeing this, and then you see this. Yes. But the best clue was descending aorta. Start there. Diastolic runoff is there. See, this is not a pulsatile. See, this is there diastole. It's not reaching the baseline. It's going to this. And gradient is around 86. Anyway, even if the gradient 30 here, what I have to do? Because LVH is there. I will try to see that part. See, I can appreciate, but In adults, it's not a good advice, but it's there. It's there, but in pediatrics you will see better shelf here. And I would go with this color. This color flow is really convincing to call it a coact, and rest of the arch is okay. So ascending aorta, transverse arch, descending aorta, isthmus, all is normal. So this is a simple coact, and no VSD, no parachute complex, yet to see bicuspid or tricuspid aortic valve, rest all is okay, no PDA also. All agreeing with me? Turn करो, left turn कीजिएगा फिर से.
Even if it's a bicuspid aortic valve, it's not going to make any difference.
Yeah, just for the diagnosis, otherwise we are not going to do anything for this.
So ideally it is lower down.
Yes. In this patient, I would go for a stenting directly.
Self-expanding stent
Yes.
will give a very good result.
Yes.
So next time you will come for pediatric course again, we will show you this case with stenting.
So that's what. If you want to see the function, see this is a function LVH, and there is no pH. If you want to see the aortic valve anatomy, again T. That's why I said in adults, mostly you will end up with more
At least you give M mode.
M mode. For
Whether bicuspid or
no, I come.
What she is saying eccentric closure of
But imaging is not there, so M mode will also be not be there. You can try, sorry. If you,
even if it's a bicuspid, how is going to be different?
Yeah.
The only natural thing is you can look at the flow velocity.
yes.
That's all.
So if this by this stage nothing has happened for the bicuspid valve, it's unlikely to cause trouble.
This domain also is maybe due to hypertension.
Yes.
No,
Yes.
no, no.
Which one? Doming means?
Domain can never be due to hypertension.
PDA is similar to VSD, almost similar in terms of physiology. Post-tricuspid shunt, every post-tricuspid shunt is same physiology. So there is not much difference in understanding. So if we revise the PDA or VSD, I will revise again here and make it slightly simpler to understand physiology first. So if I make the heart like this, there is a VSD or a PDA. Either. हाँ अभी इसके बाद यूज करते हैं. I just make the heart normal and then abnormal. So this is the VSD and PDA. Either of things, the things will remain same. How? I am talking about PA and aorta. Okay. So anyone can tell me what is the pressure of aorta and what is the pressure of LV in adult, normal adult? So if I say it's 120 systolic, LV pressure is?
if there is no obstruction.
If there is no obstruction, so 120. What is the normal systolic PA pressure? Approximately 25 systolic. Around 30, 32, 30 ले लेते हैं. For the calculation 30 is easy, but it's not 25, 30 at least. 30, some people 35 also. So this is the systolic pressures. Okay. What I'm trying to see is, can I calculate PA pressures based on shunts? That was discussed in the earlier class also, VSD. Similar things happen in PDA. Because I am looking for gradient across PDA or gradient across VSD. That is giving a difference between LV and RV, aorta and pH. Similar things. So if I get a gradient of, in this patient, gradient of 100, the pH pressure is 20, either PDA or it doesn't matter, no. Similarly, if the gradient is less, 20, what is the pH pressure? 100. So that's all. Now, based on pH pressures, now the question is child is Eisenmenger or this is part of shunt? Two questions. pH means, suppose this gradient is 20 here or here. So pH pressure is, systolic pH pressure is 100. Severe pH. So I am worried about one question, which is this child is operable or not. That is the question now. How to decide that? But if the VSD is there, the septum will be not be giving you hints. Equal pressures, no? दोनों तरफ equal pressure है, it will not move. It happens only in ASD. In VSD it will not happen. The septum movement. You understood? It's a bypass here, no? Shunt direction will help you. If the shunt is going right to left, then I am worried that this child is not good. But if shunt is left to right, operable. That one thing. Second is saturations. Sats are normal, shunt is left to right, this child is operable. So if the child is 6 months old, 1 year old child with large shunt, but shunt is still left to right, sats are okay, and other criteria of X-ray are there, then I am thinking this patient is operable. The problem is large VSD. Suppose VSD is so large, the pressures are equal. Large VSD means pressures are equal. So always equal. No? Since birth they are equal. So how can the child is Eisenmenger at 1 month of age? By based on pH pressure alone. It's not possible. You understood what I am trying to say. So if a large VSD, they will always have severe pH. Always. Because of large shunt. What we have defined, is it because of shunt or is it because of pulmonary vascular resistance? Clinical criteria, saturation and shunt direction will help you. That's what Manna was trying to tell you about the VSD. Same principle applies to PDA. Now with the PDA shunting right to left, lower limb will become blue. The child is blue in the lower limbs, sats are low in the lower limbs, child is no severe is there. Severe pulmonary hypertension always there in large PDA. That is also not a complete answer. Inoperable. This is Eisenmenger PDA. Severe pH is always a part of large shunts. That is not the answer. If you say my child has severe pH and I say small PDA, is it okay? No. If I say large PDA, severe pH, is it okay? Yes. So always was there. So it's not that child is always inoperable, no? Understood? The question in the concept has to be understood first here. Next चलते हैं अभी. Let's go to the PDA now. So one more, I will complete there first. One more thing, I will make a diagram and the thing, and then we go ahead. What first we have to understand the definition of shunts. That's what ma'am has. I will revise this. This simple diagram I have made for my fellows lot of times. Small, moderate, and large shunt. I'm talking about post tricuspid. Okay, don't mix it. Either VSD or PDA. Small shunt, moderate shunt, and large shunt. Cardiac enlargement and pH. How do I define a small shunt? In these two terms. Cardiomegaly, pH. Cardiac enlargement and pH. Small shunt means, yeah, such a small shunt. No load on the heart, nothing. Yes, this is small shunt. So if my echo says there is no cardiomegaly, my X-ray says no cardiomegaly, there is no pH, this is a small post-tricuspid shunt. I am talking about post-tricuspid, repeatedly saying either VSD or PDA. Yeah. Now we come to the large. Now come to the large first. Cardiomegaly? pH? How much pH? Severe pH, yes. So this is always there. part of large shunt. It's not part of operability. Severe PH in the large shunt is not part of operability. You understand this point? Now come to the moderate shunt. Moderate shunt means cardiomegaly, yes, PH either not there or mild. Or mild. This diagram, if you can remember, you can define PDAs irrespective of size. Because sizes in terms of millimeters will not define the severity of lesion. This is a hemodynamic classification. Yes. So if my X-ray says cardiomegaly, my echo says small VSD, I will not believe you. I will say no, something is wrong from the echo. Because X-ray is cardiomegaly. Why are you saying a small shunt? So I will look for other shunts. Maybe child has 2 VSDs, maybe a PDA also. That's what I am trying to say here. Okay. If some report says large shunt, PH not there, I would say no, something is wrong. This man doesn't know about the echo. You understood? Now if the shunt is bidirectional, that I am worried. Operability. There I am worried about operability. Child has probably become Eisenmenger. This is the point I get worried. Okay? Okay. So start with this. There is been a question change. Someone has been changed to me, but I don't know. Let me see. Okay. Full screen hai? Yes. Back. Okay. Anyway, so which chamber is dilated here? LVLA. One more thing now with this side I remember. If the PDA is having right side dilatation, PDA is having right side dilatation, LV is not dilated. That also means no, Eisenmenger. There are two different compounds of PH which we have to understand. We all have to understand. So if you have right side dilatation, this means Eisenmenger, not severe. Severe is there. Severe is always there in large shunt. That is not the question. Question is severe hyperkinetic or severe obstructive. Hyperkinetic means operable, left to right shunt. Of Eisenmenger means right to left shunt and yes. And then right side chamber will dilate, not left. Again, plex view. So again, I am seeing the LV dilatation. If you take the Z scores, I don't know where the pointer. This pointer doesn't work in between. Yeah. So this is the LV dilatation. So this is applicable to VSD and PDA both. Now this is a short axis view. Pulmonary artery is slightly bigger and I see a connection. This may be this is the aorta and this may be a PDA. We have to confirm with the color. This is the color and put the Doppler across it now. I don't know if I put the Doppler, but this is another PDA. See this PDA, this is called ductal view, slightly high parasternal ductal view, where you see a PDA and descending aorta and this is the PDA side. Now the question is where to measure PDA. Some people will measure here. Here, narrowest. Always check the narrowest point. This PDA will be given 10 millimeter here, 3 millimeter here and 5 millimeter here.
Sir, I have a question. The measurement of the pulmonary end, measurement of the aortic end and measurement of the duct. How can we make this?
So this aortic end is this. You make the aortic end here, make the PA end here. There are two ends and the length of PDA you can measure here, but it's not needed. Length of PDA is not needed, but you can measure it. So aortic end and this like this. If I run this, this is the aortic end and this is the PA end. So this is the pulmonary artery. No, this is the pulmonary artery. This is the PA end and this is the aorta and this is the aortic end. So this is called ampulla. This is called ampulla. So this is called ampulla. The aortic end is called ampulla, the other end is called PDA. So again here, see this. So I am seeing this PDA. This is the narrowest size of PDA. This is the ampulla, and this is the P end. This is the pulmonary artery, no? So this is the PD end. So this would be called as a P end, and this is the aorta. Similarly, here I would call this as the smallest P end, and this is the aortic end. This is very beautifully profiled here. So this is the aortic end from here to here. So around 8 to 10 millimeters is the aortic end. Aortic end, see, this is the aorta. No, where is the pointer? It's not coming here. Oh, my cursor is coming here. It's not showing there. Oh, so I don't know. I thought cursor is seen. So this is the aortic end, and this is the P end. This is the aortic end. So from here to here is the aortic end. This is the P end. This is the again P end, aortic end. This is a long PDA. So this is the pulmonary artery coming, and this is the P end. This is the aortic end. Okay. So aortic end is called ampulla from here to here. Now this is the Doppler across the PDA. Gradient is 82. This is a small child. Suppose the BP is 100. So PA pressure are 20. So this is a restrictive PDA. First thing. Now if I want to know in which category this comes, small, moderate, large. What you want to know is no. Yeah, you have to ask me, sir, there is a cardiomegaly or not. But I showed you earlier, LV is dilated. So this comes to be the moderate shunt. Yeah, that's the answer. Now if there is no cardiomegaly, no PH, so this patient, if the LV is not dilated, this is small PDA. If the LV is dilated, this is moderate PDA. And if the gradient is not there in the PDA, gradient is 20, this is large. And if the shunt is bidirectional, probably we are going towards Eisenmenger. And then I am looking for saturations and RV size. Okay? Yeah, this one is bicuspid aortic valve. So again, with the PDA, you always look for the bicuspid aortic valve and coact also. LA aorta ratio, we have discussed in the previous lectures also. So LA aorta ratio. Now what is the significant PDA? Ma'am was talking something, I will be somewhere. But LA aorta ratio, which is more than 1.5, is called LA dilatation. But in P terms, it's a different criteria. So there is a lot of confusion, there is a lot of controversy if you talk about preterm PDA and significant PDA. Means which preterm PDA should be ligated, which preterm PDA should be closed by drugs, which preterm PDA should go device. There is a lot of controversy. Now in our institute, we have very high resistance to the surgery nowadays. We don't do anything for the PDA because we believe PDA is a functional structure and not a disease. It's like fever in the enteric fever. So you have a fever, you don't treat the fever, you treat the enteric part. Similarly, PDA is not a disease, what we believe in our institute. But so when do we intervene in PDA in the preterm baby? When the child is stuck on ventilator, LA aorta ratio is more than 2 and child is not going ahead. Then we think of doing the intervention. Otherwise we don't give any drugs nowadays. We don't give brufen, we don't give PCM nowadays also. So we have realized that PDA is not a disease, it's a symptom. You treat septicemia, you treat the other factors, PDA will close. But anyway, that's a controversial structure. Every unit has its own protocols. This is the, again I want to show what is the PDA. On angiogram, see this is the ampulla. This is ampulla, this is the P end. This is the pulmonary artery, this is the aortic end, this is the PD end. So I want to measure this end in the echo to put a device. Okay. So just the correlation. If this can run, yeah. Yeah. So the device is released. This is a common procedure, very safe procedure nowadays. Almost no complications, the PDA device closure anywhere in the world. There are guidelines, you can go through the same guidelines. Only I will talk about contraindication of closure is silent PDA. What is silent PDA? I have not discussed here. No murmur. Silent means no murmur. So any PDA which has only on echo, no murmur, this PDA should be left alone. Otherwise all PDA need closure.
But this patient we are come approach to the adult patient has no chamber dilatation, but no murmur or auscultation, but that is PDA. Just small PDA.
So you can leave it. Leave it. There is no murmur, leave it.
How it can be possible without any murmur, no chamber dilatation?
That's what, no? No chamber dilatation, no pH.
No, no murmur.
That's what.
Yes, possible.
No chamber dilatation, no pH.
I'm saying no murmur.
Huh?
There is no murmur.
Yes. That is a very small PDA which not doesn't give any murmur. That is called silent PDA. This again, same similar FTT, bounding pulses, dilated LV, no VSD, bounding pulses. The DD is this, PDA, AP window and branch PA from aorta. So always look for these causes. I have shown the AP window in the morning. So this is a case of AP window again, LLV dilated. You see the LLV dilatation, some MR, trivial AR also, and I am trying to see the AP window. Yes. So this is very big. This is another AP window. So AP window is also not an uncommon disease. We see a lot. One more finding in the AP window is reversal in the arch. So this is another clue which I learned in my early residency days, that if you have reversal in the arch without any reason, look for AP window. Sorry? Reversal in the aortic arch. See red flow. Arch should have blue flow. See this? So reversal. The blood is going back. Why the blood will go back in any disease? There are multiple causes, but one of them is AP window. Then LV dysfunction. In the morning, which had LV dysfunction patient, this patient had reversal in arch. I did not focus on that part. So if you draw this, significant AR also, yes. So like you have aortic valve here and blood is reversing into the arch. Okay, that means the resistance is here low like AR. Dysfunction, LV dysfunction, cardiac output is low, the blood will go back. The blood will go back. Severe AS, critical AS, blood is not going ahead. Coronary has to receive blood, blood will go back. So AS, LV dysfunction, AR, the blood will go back. That is called reversal of the arch. Then here, suppose here, ascending aorta and PA connection called AP window. The blood will go, we have to supply to the, then some fistulas, like some coronary to RA fistula, RV fistula, lower pressure chamber can lead to reversal. So reversal, severe anemia, septic shock, they all can have reversal. I think this is the last from my side. Yeah. So selection of device means size. One is size. So the PA end is around 3 mm. Add 2 mm more into this, and you can do pulmonary end. And you should not cross the ampulla size. So ampulla is 6, PA end is 2. You may take 4/6/4 size. So there are 2-dimensional device. One is aortic end, one is PA end. So maybe 2 mm extra in the PA end, smallest size basically. Yeah, like in our unit we will go up to 4